Good evening, colleagues. We welcome you all tonight to this CME activity. The Southern Tagalog chapter is very proud to host this fourth chapter-initiated CME entitled Rediscovering Interstitial Lung Disease in the Era of COVID-19. We are honored by the presence of our dear President, Dr. Greg Ocampo, the Chairman of Committee on Chapters, Dr. Eileen Aniceto, and of course, Dr. Lai Garcia, the Chair of CME. Having had 3 previous equally interesting COVID-related topics, tonight we will have another exciting one, but we will divide the discussion into 2 parts. First, we will revisit interstitial lung disease and discover its relationship with COVID-19 and how do we manage such cases. Second, we will look into the CT scan findings of the different ILDs and how they differ from each other, and in particular, distinguish the pulmonary fibrosis seen in post-COVID patients. Before we proceed with the introduction of speakers, let me give the floor to our energetic but remaining to be beautiful chairman, Dr. Eileen Aniceto, for her opening remarks.
Hi, good evening to everyone. Like mentioned, this is our 4th already. I'm actually very proud of this particular initiative because aside from the chapters having a say, what the topics they want to be updated on, we have a chance to get together kahit na it's virtually. We see each other more than once a month with the way we're going. So thank you very much to everyone, all of the chapters who have participated so far. And for the rest of the chapters, I hope that you can gather more audience because our topics are also interesting and it gets interesting as we go along. So welcome everyone, and I hope you have an enjoyable learning experience tonight. Thank you.
Thank you, Eileen. Next, we call on our young and vibrant STC president, the ever-cool Dr. Lacan Beracho. Lacan.
Hi, good evening, colleagues. Okay. I would like to thank you all for spending your precious time with us. I would like to acknowledge the presence of our president, Dr. Greg Ocampo, also Dr. Eileen Aniceto, the chair of the Committee on Chapters, and also to Dr. Lisa Garcia, the chair of CME committee. Indeed, COVID-19 pandemic has taught us a lot, and we are continuously learning in its course. One of the challenges that pulmonologists encounter is the extensive pulmonary fibrosis from COVID-19 pneumonia. It seems that this problem mimics some of the ILD. Unfortunately, in my practice, I have limited experience in managing such cases. So I need to call a friend, and one of them is Dr. Albert Albay. Hence, the Southern Tagalog chapter decided to revisit ILD and see if some of the management can be applied in post-COVID-19 fibrosis, such as high-dose steroids, antifibrotic therapy, etc. The topic tonight is very timely as the PCCP main will have a webinar on COVID-19 fibrosis, highlighting on the current clinical trials this coming July 6, Tuesday. So without further ado, I would like to turn you over to Dr. Atalia to introduce our speakers. Thank you.
Yeah, so to introduce our speakers, let me just share my PowerPoint. Okay, so our first speaker is not new to all of us, no? He's a very eloquent speaker, and he is a fellow and diplomate of the Philippine College of Physicians and the Philippine College of Chest Physicians. He is a clinical associate professor in the UP College of Medicine. He is a medical specialist 3 and head Central Intensive Care Unit of the Philippine General Hospital. He is also the head of Intensive Care Unit Manila Doctors Hospital, and a consultant in pulmonary medicine at the UPPGH and Manila Doctors Hospital, Manila Medical Center, and Lung Center of the Philippines. Now I will introduce our second speaker so that the discussion proper will not be interrupted. Okay, so our second speaker is a graduate of the UERM, MMC, and he had his residency in radiology at the Philippine Heart Center. He had his fellowship in CT MRI at the same institution, and he is also a fellow and diplomate of the Philippine College of Radiology and a fellow of the CT MRI Society of the Philippines. Okay. His hospital affiliations currently are Lucena MMG General Hospital, Caloocan City Medical Center, Rosario Medical Hospital, and Lung Center of the Philippines. So we have our two speakers. The first is Dr. Albert Albay, and the second, Dr. Julius C. Oliveros. Let's give them a warm round of applause. Okay.
Thank you very much, Dr. Cynthia, for the introduction. And thank you to the PCCP Southern Tagalog chapter for the invitation to be with all of you tonight. And let me just share my screen. So I was given a long topic to discuss, but we'll try to synthesize everything in the amount of time that have been given to me. So we'll look into rediscovering interstitial lung diseases in the era of COVID-19. And these are my disclosures. Our objectives will be to provide everyone with an overview of the various interstitial lung diseases, and we'll review the clinical evaluation and diagnostic process that has been brought forth by the ATS and the various societies. We'll highlight the challenges and the potential solutions in evaluating and managing ILDs in the setting of the COVID-19 pandemic. And then finally, we'll give you an overview of the emerging concepts of post-COVID-19 fibrosis. So interstitial lung diseases are part of the diffuse parenchymal lung diseases. They are a heterogeneous group of non-neoplastic disorders that result from damage of the lung parenchyma by varying patterns of fibrosis brought about by inflammation. They are lumped together because they do share similar clinical or radiologic or physiologic or pathologic manifestations. And by virtue of having that term interstitial in the category, it means that the pathologic abnormality often begins in the interstitium. However, this does not preclude that the disorder can reach, or there may be extensive alterations as well, of the alveolar and the airway architecture. So we have two documents on consensus statements from the ATS, ERS, and the various societies regarding interstitial lung diseases. So this is the latest coming from 2013, wherein they have classified ILDs into those of the diffuse parenchymal diseases. They are grouped together with those with known causes, for example, drug-induced or associations with exposures, or if you have CTDs or connective tissue disease, for example, rheumatic diseases. These will also include those granulomatous lung diseases, for example, your sarcoidosis, and other forms of diffuse parenchymal lung disorders, such as your pulmonary LAM and your pulmonary Langerhans cell histiocytosis. Your idiopathic interstitial pneumonias will often be divided into those of the non-familial or familial. Again, there's a small percentage of familial interstitial pneumonias or IPFs. And the 2013 document does tell us now that before they just have this 6 entities of interstitial pneumonias, and now they are grouped into 3 categories or 3 subtypes. We have the chronic fibrosing, to which are IPF, and your idiopathic NSIP or non-specific interstitial pneumonia will belong. And these are the conditions where we have to be very much aggressive. I think that's the reason why they were lumped together, because these are the conditions with the potential for progressive fibrosis and debilitation to our patients. And then there is a second group of acute or subacute fibrosing parenchymal disorders, to which includes your COP or cryptogenic organizing pneumonia. In the previous 2003 document, this was the COP, this was the book, and you have your acute interstitial pneumonias. And there are smoking-related ILDs, which includes your RV-ILD and your DIP or desquamative interstitial pneumonia. This is quite important because sometimes removing those inciting agents might be a key to controlling the conditions in this patient. The 2001-2002 document carries with them these radiologic patterns of the different IIPs that I think our second speaker will be able to discuss with us. So take note that in this 2002 document, there are 7 different interstitial idiopathic pneumonias. The LIP is now lumped together with the DPLP of other types. And then CFA, or your cryptogenic fibrosing alveolitis, which has been used as a terminology by the Americans, have now been removed and being replaced with just IPF for uniformity. So how does ILD present? Often, your interstitial lung disease patients will come to you with a symptom of progressive dyspnea or a persistent non-productive cough. This is a key determinant that you might be dealing with ILD, the presence of that non-productive cough and the progressive dyspnea. There might be this might be a pulmonary symptom of another systemic disease. For example, if you're able to elicit that this patient had a connective tissue disease like scleroderma, lupus, or rheumatoid arthritis. You might be able to see that this symptomatology would carry with them also a history of occupational exposure, for example, asbestos, silica, or even exposures to livestock or animals. Some patients will just present with an abnormal chest imaging and will be sent to you for investigation. Now, some, if they had a pulmonary function test for one reason or another, there might be a lung function abnormality on a simple office spirometry, often of a restrictive type, and they are given to you or sent to you for clinical evaluation. So it is quite important that in evaluating ILDs, a detailed history be made for all of these patients. Take note that the age is a factor that can help you narrow down your diagnosis. For example, patients who are 20 to 40 years old will have this lumped together of ILDs. You have your sarcoidosis, your CTD-associated ILDs, your LAMS, and your pulmonary Langerhans cell tissue-cytosis. Idiopathic pulmonary fibrosis, because it's a progressive disease, often are seen in patients above 50 years of age. Now, the gender is also quite important. It might be a good consideration. You see that your premenopausal women can be the ones who will develop your LAM or your lymphangiomyomatosis, and they can be part of the pulmonary involvement of patients with tuberous sclerosis, which is a syndrome brought about by their genetics, wherein they usually have childhood seizures, the development of renal amyloidosis, and LAM that has been there. They say that occupational exposures are more common in men because of the type of work that they have. So usually they get involved with those mining activities and also exposures to animals. The duration of symptom is important as well, and it can help narrow down your differentials or the causes of your particular ILD. So these 2 weeks of manifestation can be any of the following. You have your AIPs, your eosinophilic pneumonias or hypersensitivity pneumonitis, and your cryptogenic organizing pneumonias. In contrast, the chronic symptomatology is seen more in IPF, those with chronic HP, those with sarcoidosis. And subacute manifestations can be seen in those with drug-induced interstitial lung diseases, those with alveolar hemorrhage syndromes, or those with connective tissue diseases. Now, the past medical history should be very much investigated. Look into the possibility of old or CTDs in the past, presence of inflammatory bowel diseases, previous malignancies, because you need to deal with what are the cancer agents that have been given to them in the modalities. Histories of asthma or allergic rhinitis may point to a patient having eosinophilic pneumonias or a probable Hrct disease. Now, smoking history is again important. There are conditions or ILDs which are strongly correlated with current or former smokers. And this includes your RB-ILD, your DIP or desquamative interstitial pneumonia, and your IPF. Now, for your sarcoidosis and your hypersensitivity pneumonitis, these are often present in non-smokers. So you rarely would see patients with this condition who are with a significant smoking history. Now, again, familial history of ILD is important for us to check. So IPF can be familial as well in about 2 to 20%. Again, some involvement like LAM can be found in, can have a strong genetic basis. So you might want to look into a history of pneumothoraces or catamenial pneumothorax in the family, in the other members of the family. Now, medications, I just listed here some of the medications that are quite important to consider because these are the ones that we are seeing more and more because of our improvements in healthcare. So take note that some cardiac medications can give rise to interstitial lung changes. So for example, your amiodarone. Cancer medications are also known to do that. And of course, radiation by virtue of having your radiation pneumonitis. Over the past 5 years, we have been seeing increasing amount of literature on your checkpoint inhibitor cancer medications, which are used predominantly in oncology and even in hematology. So you might see patients who have been placed there developing a fever and an acute condition like fever together with a diffuse parenchymal infiltrate that you might think it's pneumonia, but for all you know, this is just a pneumonitis or an ILD brought about by those checkpoint inhibitors. Exposures are quite important for us to ask. Dust, gases, chemicals, livestock, animals, and birds. Important also to check a thorough history of their travel history as well as their recreational activities. So some patients might dismiss these activities and will find that they are not that significant. I had a patient before whose exposure for developing the seemingly diffuse parenchymal damage was with hunting, and he was doing this for about 5 to 7 years. He was hunting bears, and that was the source of his exposure and the destruction in the lungs that was eventually confirmed in the surgical lung biopsies. The physical examination often are non-specific when you look into the lungs, although the literature will tell us about Velcro rals being described in most forms of ILDs. The cardiac examination will often be normal, except in advanced cases wherein the pulmonary fibrosis has already gone into a complication of pulmonary hypertension or cor pulmonale. Clubbing is a late manifestation of the disease as well. And again, part of the history and the possibilities that these DPLDs might be a manifestation of other systemic diseases. So do a thorough physical examination and looking into the extrapulmonary findings of systemic diseases as well. So the 2013 guidelines from the ATS and ERS tells us that for patients who you found to be suspected of ILD, the initial step is to do that initial clinical evaluation, focusing on the history, physical examination. And because CTDs are quite common in these ILDs, you do a serology of your CTD. You might want to do a referral to your rheumatology if you see a particular pattern of CTD that you might want to check. You do a chest Hrct and a pulmonary function test to determine the DLCO, the degree of involvement of the parenchyma, and the restriction in the movement of your lungs as well. And then if, for example, the investigation gave you a potential cause, then this patient is not likely an IPF, and you go for that particular diagnosis and you treat accordingly. Now, if you are not able to find a specific diagnosis and the patient seems to be one of those idiopathic interstitial pneumonias, you go for a chest HRCT. And based on the HRCT, because again, IPF is the more catastrophic and the more problematic condition among all the ILDs, you would like to look into the HRCT scan patterns and determine whether this is a definite UIP or again, that's part of IPF or probable indeterminate, and this will be discussed by our second speaker, so we'll not go into much details about this. Now, If you're able to see that the pattern is consistent with the UIP, you go for a multidisciplinary discussion. Or if you feel that the HRCT pattern is probable or not that suggestive or is indeterminate for UIP, you still go for an MDD. And the multidisciplinary discussion has been placed in the 2013 consensus. It is a dynamic integrated approach to the diagnosis as well as the therapeutics when it comes to ILD patients. It did replace the gold standard, which is before a histologic diagnosis, and it requires a close communication between the clinician, the radiologist, and whenever appropriate, the pathologist if you decide to do a tissue diagnosis. Here, the clinical data, which includes the ones that we have discussed in the history, together with the lung function, laboratory, and radiologic findings are essential in arriving at a multidisciplinary diagnosis. And the good thing with this MDD is that it is able to define the setting where you would really need a biopsy because it becomes more informative, or whether the HRCT together with the clinical data is enough for you to give a good diagnosis that this patient has IPF. Okay? So if the patient has UIP and based on the MDD, you did agree with a 90% certainty that this patient is likely UIP and IPF, then you already proceed with the management for IPF. If based on your MDD, then you are quite unsure, then you might want to subject your patient with a surgical lung biopsy and an addition of a bile, and then go for an MDD again and review from the history, the HRCT, plus the pathology specimen, and then provide a diagnosis, whether this is, again, IPF or a probable IPF or an unclassifiable ILD, and then treat accordingly. So these are the histologic patterns and features that are consistent with how your pathologist would be discussing or telling you whether this is UIP or probable UIP. So these are the features that they would be looking for in their pathology specimen. And this is how you would now base your decision whether this is IPF or not. Okay, be looking into the probability of if your histopathology specimen is UIP and then your HRCT is UIP, then this is definitely IPF. Okay. If your HRCT pattern is consistent with UIP and then your histopath shows probable UIP, then this patient is likely IPF and you would treat this patient as such. Now, only those cases, for example, if there's indeterminate and the UIP histopath is also indeterminate, then you have to have another discussion on how to go about it. So take note that sometimes the diagnosis becomes indeterminate or another ILD might be there because some of these connective tissue diseases are in evolution. So sometimes the conditions would manifest over the coming months and coming years for you to really arrive at a diagnosis. Now, part of the 2013 document also tells us that after you have diagnosed your patient into one of the IIPs, then you look into the clinical behavior, because the clinical behavior will determine what is your goal of management and how often you would be following up this patient. So for example, if your histopath or your HRCT and your clinical picture is consistent with IPF or some of those fibrosing NSIP, these are the chronic fibrosing diseases, then these are progressive and often irreversible. The goal of treatment is to slow down this progression, and the monitoring would be long-term because you want to prevent this patient from progressing fast with their disease. And if it is available, consider planning this patient for transplant eventually. Or if the transplant is not available or the patient is not a good candidate for transplant, plan for effective palliation. On the other hand, for example, you ended up with a diagnosis of RB-ILD. Again, this is one of those smoking-related ILDs. These are often reversible and self-limited. So removal of the possible cause, if it was smoking or if it was a toxic fume. I had a case before that it was cannabis or marijuana that was causing the RB-ILD. So removing the inciting agent and then closely monitoring your patient is probably enough to see whether that ILD would be controlled. Now, some of the ILDs might have an initial need for you to intervene. For example, your cryptogenic organizing pneumonias or those cellular NSIT, which can present to you with some degree of exacerbation. So these patients will often be given some form of immunosuppressant, often steroids. So you would give or initiate these patients with steroid therapy and do short-term observation and determine whether this patient will have a need for long-term steroids or maybe tapering and maybe giving it during exacerbations. Okay. Now, in the setting of the pandemic, there are now restrictions. If you look into this, there might be things that we not be able to do. So, for example, the literature now tells us that pulmonary function test is an aerosol generating procedure. So the move towards evaluating potential ILDs during this COVID-19 pandemic will be to really maximize your consultation using telemedicine or video conferencing. By doing that, you're able to do your step one, which is your history. You'll be able to order your CTD serology and probably order your Hrct. And with the advent of the internet, you might have access to the Hrct data or plates already, and you can determine or evaluate that. The goal during the management in the pandemic era will be to minimize the delays in the diagnosis of ILD. Again, you want to make sure if your patient has IPF or not, because it's progressive and it can be fast. So minimize the delays in the diagnosis and institution of management while avoiding the non-essential contact with the healthcare system. So some of the suggestions will be to consider performing this test at off-peak hours. For example, at the time wherein the CT scan room is not heavily filled with patients, do online reservations to minimize time in the waiting room, and institute or avail of mobile laboratories for your CTD serology. Now, some patients will still need to perform your pulmonary function test, but you only perform this test if they are needed and they would provide information that will influence your short-term management. Okay. Now, it also highlights that during this pandemic, you try to hold your multidisciplinary discussions virtually and try to maximize them. This should be held together with an ILD clinician and a chest radiologist, and include a lung pathologist in the MDD if you want to determine whether there is an urgency of doing the invasive procedures like your surgical lung biopsy. This becomes quite important because sometimes, like if you're in the Southern Tagalog chapter and then you want to send this patient to evaluation by an ILD clinician in Manila, they would really need to travel, and you might want to cut down on that because it increases their exposures to possible COVID-19 and their contact with the healthcare system. So MDDs done virtually can be done to mitigate that problem. Now, prior to the pandemic, the PCCP, together through the Council of ILD, has been equipping some of our training institutions or most of our training institutions on how to organize these multidisciplinary discussions, because most of the institutions, the training institutions, do have experts in them. They have radiologists and pathologists who can help conduct these multidisciplinary discussions. So during the setting of the pandemic, this becomes quite important for us. So maybe the way to go for us private clinicians who might not be attached to an academic institution that might not have an access to a full team of radiologists or lung pathologists will be to activate the MDD through the PCCP. Maybe contact the Council of Interstitial Lung Diseases and help set up an MDD where you can present your patient and the PCCP can assist in calling radiologists from the different training institution or pathologists and experts for the training institution to help you diagnose your patient and go through the algorithm. So the MDD will conduct all of these other tests and other parts of the evaluation, basing on whether they would have an impact in the short-term management. The MDD should be able to determine with certainty if the patient has IPF or not based on the images. So the recommendation now tells us that if, for example, based on your HRCT pattern together with your serologies, history, and PE, you are 90% certain that this is IPF, then you would now defer further testing in this patient. If you have 50 to 89% certainty, maybe you are on the probable UIP, you might want to balance off together with your MDD whether to pursue additional tests like surgical lung biopsy versus observing your patient and following them up closely, versus if the patient seems to be deteriorating or has some progression, maybe instituting empiric treatment and then proceed with testing after the pandemic is resolved. Okay. Now, for some patients whose certainty that this is IPF is less than 50%, the MDD will discuss and make a decision whether it is enough because the patient seems to be stable to observe this patient, or if there's an urgent need for a because you want to plan a therapeutic disease or there's a therapeutic implication, you might really need to proceed with the urgent test and plan out how to do that because it will influence your management. So more often than not, during the COVID-19 pandemic, the BAL and the surgical lung biopsies are not performed because of the restrictions and the aerosolizing procedures and the difficulty in accessing OR schedules because of the COVID-19 pandemic. But if you do consider placing your patient or subjecting your patients to this procedure, you need to mitigate the aerosolization during these invasive procedures as well. Okay. Now, for patients who you feel these patients should still be reassessed during the time that you have the pandemic and maybe do all the other tests once the burden of COVID-19 in your area has already been controlled. Maybe you can now do your pulmonary function test. Maybe you can now do your surgical lung biopsy or subject your patients to such. Okay. Now, these are the treatment options that are available for interstitial lung diseases. So we have your pharmacologic, non-pharmacologic, and of course, lung transplantation. So let's take a look at how this would have been modified in the setting of COVID-19 pandemic. So some of your ILD patients will have immunomodulatory agents. These would come in the form of steroids, mycophenolate, azathioprine, cyclophosphamide, or even rituximab, depending on the underlying pathology that is seen on their specimen, and if there is a systemic counterpart like a connective tissue disease in these cases. There is no robust data to say that if you start or maintain patients with fibrotic ILDs on these immunomodulatory agents, that their risk for COVID-19 is increasing. But we can extrapolate data coming from previous coronavirus outbreaks. So in the SARS and the MERS-CoV outbreaks that have happened in the past, patients who have ILDs, who have been given or initiated or maintained on immunomodulatory agents did not show a higher risk of developing these severe viral illnesses. So this might be a point for you to consider initiating or maintaining your patient on these immunomodulatory agents as long as they have this fibrotic ILD and their risk-benefit ratio favors you providing them with immunomodulatory agent. The MDD again can be a way for you to help decide whether to keep these patients or to start these patients on immunomodulatory agents. The MDD will have to balance their approach with their initiation of therapy. Again, if the clinical behavior seems to be of the progressive type, it is reasonable to institute immunomodulatory therapy. The dictum there is preferably limit the use of your corticosteroids and maximize your steroid-sparing options because of a lot of complications with your corticosteroids. If the likelihood of progression is limited or is small, then you might consider delaying non-urgent immunomodulatory therapy in this patient and just monitor these patients closely. Now, for example, if the patient has already been maintained on a regimen of immunomodulatory agent and seems to be well with your dose, should you adjust or reduce the dose? There's still not much guidelines on when it comes to that. But the dictum is you consider probably maintaining these patients on the dose, provided that it is not causing you some side effects brought about by the immunomodulatory agent. Again, the dictum is probably not to take them off these immunomodulatory agents because you run the risk of their condition getting worse, but maybe maintaining them on the least or the lowest dose possible. Again, prioritizing steroid sparing therapy. Now, there are two antifibrotic therapies that are available to us. We have perfenidone, whose mechanism of action is quite not that, it's really not that well known, except that we know that it's an oral antifibrotic drugs with pleiotropic effects. In vitro studies has shown that it can regulate important pro-fibrotic and pro-inflammatory cytokines. And in animal models, it has been shown to reduce fibroblast proliferation and collagen synthesis. Then we have nintedanib, which is an intracellular inhibitor of your several tyrosine kinases. And because they inhibit these tyrosine kinases, they can target multiple growth factors, which are important in developing fibrosis. And these includes your VEGF, your fibroblast growth factors, and your platelet-derived growth factors. These are just the studies on perfenidone and IPF. Suffice it to say that the studies on perfenidone being given to IPF patients on a long-term basis have been shown to delay the progression of the condition by reducing the rate of decline in their lung function, predominantly in your FVC, and a rate of decline or reducing the decline in function for their exercise capacity through your 6-minute walk test. Nintedanib has also studies on IPF, again showing similar promise that they are able to reduce the incidence or reduce the speed by which the lung function deteriorates, which is your goal in IPF management. Now, from these two antifibrotics, because of their work on pulmonary, idiopathic pulmonary fibrosis, and we are expanding knowledge on fibrosing ILDs, we now know that there are ILDs other than IPF which have this progression of fibrosing conditions. So these might be some of their NSIPs, some of those with connective tissue disease, or some of those with drug-induced ILDs. And they do have studies on these progressive fibrosing ILDs. So the RELIEF study is the perfenidone versus placebo on these progressive fibrosing ILDs, not necessarily IPF, all of those other fibrosing ILDs. This study was terminated earlier because of slow recruitment, but the 147 patients that they were able to enroll in the study and their analysis, they have been able to show a significant reduction in the rate of decline in their FVC. The InBuild study was completed, and this is nintedanib versus placebo, and their primary endpoint was again a reduction in the progression of lung function, and they were able to show a reduction in the rate of decline of their FVC. So these studies are the reasons why maybe because your COVID-19 is a some of the COVID-19 patients will go into a progressive fibrosing type. This might be extrapolated to them. But remember that the RELIEF and the InBuild studies did not contain patients with COVID-19. They do contain patients with unclassified interstitial lung diseases that seems to be progressive fibrosis. Okay. So how do we monitor our pharmacologic therapies during the time of the COVID-19 pandemic? So pre-pandemic, this is what we usually do. We often do blood examinations to check for inflammatory markers. We monitor our PFTs to determine extent of response and the rate of decline, and exercise capacity using your 6-minute walk test. We send our patients a lot of questionnaires on quality of life and patient-related outcomes. Now, during the pandemic, some of these tests might not be readily available or cannot be done to your patient because of the problems of contact. So those on chronic therapy, the recommendation is to reduce the frequency of this laboratory monitoring, your blood examination, your pulmonary function test, and exercise capacity, and use the stability of symptoms and globe clinical, whether to maintain your patient or adjust your therapy. And once the pandemic gets resolved or the situation in your area becomes controlled, then you can probably go for the standard way of monitoring pharmacologic response. So for patients, however, whom you will initiate therapy, it is reasonable to really do these blood examinations on the short term. Remember, some of these antifibrotics will have side effects, so you really need to monitor this patient. Now, the routine testing for pulmonary function in the setting of a high burden of COVID-19 is really not justified, and the literature would tell us to really not proceed with your PFTs as a way of determining extent of response unless you are really needing it, and it will influence your short-term decisions on therapies on your patient. There are other non-pharmacologic therapies to implement during COVID-19 for these ILD patients. Of course, adherence to standard health measures, provision of oxygen therapy to those in need should not be delayed, encourage exercise, smoking cessation, and pulmonary rehabilitation. And for this, consider virtual means for such of these engagements. You might really need to do ways of conducting pulmonary rehabilitation through a virtual means, encouraging your patients with exercise, and maybe plan out a smoking cessation tailored fitted to your patient through virtual means. Psychosocial support is quite important also, and this can be given to support groups, and you can have virtual engagement and meetings for this group of patients. Now, lung transplantation is an option that should be offered for those with progressive disease, fibrosing diseases. And if a program is in place, however, during the setting of a pandemic, it is advised to postpone all transplant except for the ones that are really most urgent. Now, what about post-COVID-19 fibrosis? So these are worrisome sequela of COVID-19 ARDS. So data coming from the previous coronavirus outbreaks of SARS and MERS-CoV have shown that some survivors did have varying degrees of pulmonary fibrosis after discharge, and some will still have residual fibrosis and impaired lung function up to 2 years after. So we are nearing the second year of our COVID-19, so we might see some more data similar to this as well. There is a question of whether this post-COVID-19 fibrosis is just similar to ARDS fibrotic phase, but we'll tell you that maybe this is more or beyond the ARDS fibrotic phase. The exact mechanism for its development is still unknown, although some hypothesis has been generated, and we'll go through some of them. When you go through all the cohorts or all the data showing to you about this post-COVID-19 fibrosis, Asian, Europeans, and Americans, these are some of the consistent things that are potential risk factors. Of course, this happens in the patients who are at risk for developing severe or critical COVID. So these would be the older age group, those who are male and had a respiratory failure needing support by whatever means of high flow, non-invasive, or oftentimes intubation with mechanical ventilation. They do have a lot of risk factors, but in the Chinese cohorts, I was able to review 3 Chinese cohorts, and they were telling us that hypertension is one of the more common things that they have seen for these patients who develop post-COVID fibrosis. Smokers seems to be at risk. The Egyptian cohort was able to show that smokers have 1.3 times the risk of developing post-COVID fibrosis compared to non-smokers. Of course, these patients do stay longer in the ICU. So I think even if they say that this is a risk factor, this might really be related to the fact that their conditions are really that bad. When it comes to the biomarkers, they say that patients who have higher IL-6, elevated D-dimer, so this is the American group, higher CRP levels have been correlated with the development of post-COVID-19 fibrosis. The group from the Koreans and the Chinese were able to show that patients who had low lymphocyte counts during their acute stay or the acute phase of their COVID-19 do carry with them a potential risk for developing post-COVID-19 fibrosis. And in the Japanese group, they were able to show that patients who have a low interferon gamma seems to be the patients who would develop this post-COVID-19. So they say that interferon gamma is an anti-fibrotic cytokine that we have. So if it is quite low, so in that cohort, they were able to show the patients who had post-COVID fibrosis, their interferon gamma was twice as low compared to those who did not develop. Okay. Let's try to take a look at the pathologic findings in COVID-19 autopsies, and this can somehow give us an idea of how this post-COVID-19 really developed. So just like with any other infection, so what happens when an agent, a virus enters into your lungs, they do invade your cells. So at the early part, you have cytopathic effects on the infected alveolar cells. So these are the big ones that you have been seeing here. And then as the pneumonia progresses, you begin to have that acute fibrinoid organizing pneumonia. So a typical pneumonia for your patients. Now, some of these patients will go into ARDS, and we all know that during the initial part or the exudative part of your ARDS, you have diffuse alveolar damage. So these are in some of the pathology specimens. This is diffuse alveolar damage with intraalveolar hemorrhage. You have formation of hyaline membranes with your DADs as well. And peculiar to COVID-19, some of these patients will not only have these DADs, they would also have thromboembolism. So there is endothelial dysfunction in COVID-19, and this contributes to the hypoxemia in the pathology the manifestations that you see in COVID-19. Now, some of these patients will progress and will develop organizing pneumonia. So similar to a COP-like picture. So you see a lot of these inflammatory cells there that seems to be organizing. And some can go into fibrosis and produce this fibrosis collagen deposition in the interstitium, similar to a non-specific interstitial fibrosis that we see in the other ILDs. So if you take a look at this journey of the lungs in COVID-19, it would seem that from an infection, you go through the phases of ARDS. You go to the exudative phase with your DADs, then you go to the proliferative phase with your organizing pneumonia. And some patients would go into this NSIP or this fibrotic phase. No? So these are potential areas of therapy that you might want to look into. How can we prevent our patients from going into this? Okay. So these are the potential mechanisms behind post-COVID fibrosis that had been proposed in this review article. In this review article, it is said that it is not only the ARDS and the risk factors for infection and the cytokine storm that creates our problem with COVID-19. They say that the presence of the virus attaching itself or having close affinity with the ACE2 receptor and activating that renin-angiotensin system leads to a lot of endothelial dysfunction and changes in the alveolar epithelium. The alveolar epithelium undergoes a lot of modification and mesenchymal cells get activated. And with mesenchymal cells getting activated, there is an increase in protein there in the basement membrane, deposition of collagen, and this promotes fibrosis. And they say that the inflammatory markers are just maybe your guide to say that this patient really has a heightened inflammation. And again, interferon gamma seems to be an important element there. So if you have a high interferon gamma, you have a high antifibrotic property in your lung, then maybe you will not go into a post-COVID fibrosis. But the problem is most of these patients who had post-COVID fibrosis do have very low levels of interferon gamma. Now, what are the known triggers for you to set this stage for post-COVID fibrosis? They say that bacterial superinfection is one of them. Problems with mechanical ventilation. So where you are not really doing lung protection strategy and promoting your patient to developing villi or ventilator-induced lung injury, do promote or set a stage for you developing post-COVID fibrosis. Now, there is data also telling us that increased oxygen delivery, hyperoxia in these patients with COVID-19 can set that stage for developing post-COVID-19 fibrosis. So you might really want to stay in what the WHO tells us between a 93 to 96 O2 saturation and not really target 100% PO saturation in these groups of patients. Because with high flow of oxygen, you promote reactive oxygen species, and these reactive oxygen species activates the RAS system and again promotes that cascade of deposition in pulmonary fibrosis. So what are the reasonable strategies that have been recommended to mitigate this risk. The goal is to minimize the factors implicated in perpetuating that cycle, leading to your persistent lung injury, prolonged inflammation, and fibroproliferation. And you do that by maybe giving or halting or decreasing the load in your lungs from the virus, giving your antiviral therapy. So again, remdesivir has been shown to have greatest benefit early on in the clinical course in mild to moderate disease. Steroids might be a way to go about it, as it is able to control that inflammatory response. So remember the recovery trial, moderate dose of dexamethasone, reduce the need and days on mechanical ventilator, and has reduced the risk of immune-mediated and iatrogenic lung injury. Then villi prevention, by doing your lung protection strategy. So you really look into your plateau pressures, your driving pressures, and look into all of those conditions in your ARDS as well, and try to prevent your patients from going into a possibility of patient self-inflicted lung injury. So minimize your patient having that rigorous respiration. So it is counterproductive to your patient and it injures your lungs more. So maybe sedate this patient, provide neuromuscular blockade, judicious ventilatory support. And if you really want to prevent your patient from going into villi, then maybe do early proning for these groups of patients as well. Now, what about antifibrotics in COVID-19? So the potential rationale that has been thought of is that maybe the way to go about for antifibrotics is give them during the active infection to avoid the lung lesions, or either reduce or prevent functional decline when you see that these patients are already in that irreversible fibrosis. Nintedanib has a potential effect in reducing exacerbations of IPF. And these patients usually present with DADs, and this is probably the reason why it can be thought of that again in the early part of ARDS, DADs are there, then maybe we can consider doing early use of nintedanib. Again, these are potential mechanisms, and there are no studies yet to show that it is actually going to do such. There are also thoughts of maybe we can combine antifibrotics. Again, we still don't know. The safety, efficacy, subgroups, and the timing and duration for use of these antifibrotics have not yet been determined. Now, how about steroids? The steroids have been known to be quite beneficial in your cryptogenic organizing pneumonia. So if you remember, during the proliferative phase of your patient, you might see an organizing pneumonia pattern in them. And this might be the best time for you to really institute your steroids. No? Again, the dosage duration has not been established. And then whether you can use it for longer periods of time, we still don't know. Prolonged use may be favorable in some subgroups, but again, the question is how to determine whether your patients are in the organizing pneumonia stage. Are they in the DADS or are they on the organizing pneumonia stage already? So these are a lot of the therapeutic unknowns that we know that we are looking into post-COVID-19 fibrosis. What are the strategies to reduce severity and progression? Which patients would benefit from doing all of this treatment, the timing, duration, and of course, looking into the side effects. Know for a fact that there are a lot of case reports already on these antifibrotics, all of these other medications, but then again, they are in a setting of case reports. No? So we still don't know whether it will be proven beneficial later on. When you look into your clinicaltrials.gov, these are all the ongoing trials that are looking into post-COVID-19 fibrosis. You have antifibrotic agents of pirfenidone and nintedanib versus placebo, or a head-on comparison between pirfenidone and nintedanib. There is an ongoing study on colchicine. There's a steroid study looking into prednisone and prednisolone. There are studies on spironolactone, sirolimus. There is also autologous monocyte therapy that is being given, resveratrol capsules, and there is one trial there that I actually don't know what is the component, but it is a Chinese medication, the Fujian Huayu tablets. I still don't know what is the component for that. So these are our take-home messages that interstitial lung diseases do require a detailed clinical evaluation. It can be done despite the COVID-19 pandemic, but you have to balance diagnostics with the risk of exposure to the healthcare system. And your multidisciplinary discussion is needed more than ever during the pandemic for patients with a clinical suspicion of ILD. both for diagnostics and decisions on therapeutics. Post-COVID-19 fibrosis, their knowledge here continues to expand. And I do hope that you keep on reading the literature as we get to know more about this condition. So thank you very much for listening.
Thank you, Dr. Albay, for that very, very enlightening lecture. And we now proceed to our second speaker, who will discuss the CT scan findings of the different interstitial lung diseases. Dr. Oliveros.
Hi, good evening, everyone. Can you hear me properly po?
Yes.
Okay ba? Okay. Wait lang po ah. Sorry, I'm having some technical problems right now. Okay. Can you see my screen properly?
Yes.
Okay po. Good evening, everyone. I am Dr. Julio Zoilo Z. Oliveros from the Lung Center of the Philippines. First, I'd like to acknowledge my co-lecturer, Dr. Albay, who I haven't met in LCP, but I do hope to meet in the future. Good evening po, sir. And I also would like to acknowledge Dr. Ocampo and Dr. Aniceto. Good evening po. And I would like to thank the PCCP Southern Tagalog chapter, most especially to Dr. Beracio, President, and Dr. Lemuel Lee, the chairman of the CME committee, and finally to Dr. Lena Lin Luceño, who extended the invitation. Thank you for giving me the opportunity to share some knowledge on the radiologic features of ILD and some in post-COVID ILD. So this will be a two-part lecture, but I'll try to go fast since Dr. Albay has already discussed a lot of the stuff about interstitial lung disease. And part one, the objectives are as follows: to discuss interstitial lung disease, idiopathic interstitial pneumonias, idiopathic pulmonary fibrosis, and usual interstitial pneumonia. We also want to discuss the role of Hrct in the diagnosis of interstitial lung disease, and to learn the general patterns of Hrct abnormalities seen in ILD. Part two of our lecture would be about COVID-19 and ILD, and the objective is to learn about the evolving knowledge of ILD after COVID-19. So what is interstitial lung disease, as Dr. Albay discussed earlier, is also known as diffuse parenchymal lung disease, and according to the European Respiratory Society White Book of 2000, published in 2013, ILD results from damage to cells surrounding the alveoli, leading to widespread inflammation and fibrotic scarring of the lungs. Here are some key facts about ILD. There are more than 300 different ILDs in about, but a large majority are very rare. Environmental factors are recognized in about 35% of people with interstitial lung disease. And among the different ILDs, some of the most important are sarcoidosis, idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, ILD as a feature of connective tissue disease, and drug-induced ILD and pneumoconiosis. So idiopathic pulmonary fibrosis and sarcoidosis are the most common forms and account for 50% of all the ILDs. And survival rates range from 20% for IPF to 100% for organizing pneumonia. Now this table shows the classification of ILD lifted from the ERS White Book, showing us that around 65% of all patients with ILD belong to those of unknown etiology. And for tonight's lecture, we would be focusing on IPF, idiopathic pulmonary fibrosis, which is a subset of idiopathic interstitial pneumonias, or our IIPs. Now, the idiopathic interstitial pneumonia is a subgroup belonging to major ILDs of unknown etiology. So this is a heterogeneous group of non-neoplastic disorders resulting from damage to the lung parenchyma by varying patterns of inflammation and fibrosis. In 2002, this was already shared with Dr. Albay earlier, the ATS and ERS classified the IIPs And an update was made in 2013, classifying the major IAPs into 6 entities that we are familiar today. So we have the idiopathic pulmonary fibrosis or IPF, the idiopathic non-specific interstitial pneumonia, which is NSIP, our respiratory bronchiolitis, interstitial lung disease, our desquamative interstitial pneumonia, cryptogenic organizing pneumonia, and acute interstitial pneumonia. Among all these IIPs or interstitial pneumonias, the most common, comprising 55% of all IIPs, is our IPF or our idiopathic pulmonary fibrosis. IPF is defined as a specific form of chronic, progressive, fibrosing interstitial pneumonia of unknown cause, occurring in adults of around 50 years old and older. It is characterized by progressive worsening of dyspnea and lung function and associated with poor prognosis, with median survival time ranging from 2 to 4 years. Lung transplantation can be considered as an end-stage treatment. And for our lecture tonight, I'd like to emphasize that UIP, or the usual interstitial pneumonia pattern, is the histologic and radiologic pattern of IPF. So UIP, the hallmark of IPF is UIP, sorry. Now, in the diagnosis of ILD, the gold standard is multidisciplinary discussion, as what Dr. Albay discussed a while ago. And MDD is a dynamic and requires close communication between the clinician, the radiologist, and the pathologist, and other specialties as needed. So after obtaining your clinical history, your chest radiograph, your pulmonary function test, and other labs, the clinician should be in a position to decide whether the patient has an ILD of known cause, so yung mga rheumatoid arthritis, connective tissue disease, and all, or whether a form of idiopathic pneumonia needs to be considered. And if we're suspecting an idiopathic interstitial pneumonia, this usually indicates a high-resolution chest CT scan or an HRCT. Now, the HRCT is an integral part of the evaluation of patients with ILD, and more specifically, IIP. Classification of IIPs is based on histologic criteria, but each of these histologic pattern is associated with the characteristic CT scan pattern. So this table was lifted from the ATS ERS guidelines, and this just shows that for our clinical radiologic pathologic diagnosis, there's an associated radiologic and pathologic morphologic pattern. So for our chronic fibrosing interstitial pneumonias, we have the idiopathic pulmonary fibrosis and NSIP, and the pathologic and radiologic pattern are UIP and non-specific interstitial pneumonia, and so on and so forth. Now, to illustrate the importance of HRCT and IIP, this table from the original 2002 ATS ERS guidelines also shows the radiologic features and differential diagnosis on IIP. Now, for our lecture tonight, I would focus more on UIP because if we remember from the diagnostic algorithm that Dr. Albay presented a while ago, one of the purposes of HRCT is to actually separate UIP from the rest of all the IIPs. So, because UIP is the one that's as progressive and progressive fibrosing and chronic disease. And if you look at here at this differential diagnosis, a lot of the like for example in UIP, the differential diagnosis also include the other interstitial pneumonias, and even here in DIP and the desquamative interstitial in RBILD, sorry, desquamative interstitial pneumonia is also included, as well as NSIP. So what I'm saying is all of the findings are actually non-specific, and there is really an importance of the multidisciplinary discussion to diagnose interstitial lung disease. Now, the role of HRCT in the diagnosis of ILD is to determine the presence or absence of a pattern typical of UIP or usual interstitial pneumonia. This is because in more than 50% of cases suspected to be IPF, the typical and clinical HRCT features of UIP is sufficiently characteristic enough to allow confident diagnosis and eliminate the need for surgical biopsy. So in more than 50% of cases, if we see UIP in the HRCT, and then that could be there's no need for biopsy, but that's not always the case. So anyway, in other words, the primary role of HRCT is to separate patients with UIP from those with non-UIP lesions or those with less specific findings associated with other idiopathic interstitial pneumonias. Now, to illustrate this further, this is the proposed diagnostic algorithm from the ATS-ERS consensus in the diagnosis of ILD. I just wanted to show this algorithm again because here we see the central role of HRCT and NDD. So after doing all your clinical history, your physical examination, and all those, um, we order a chest HRCT, and then we radiologists try to separate the UIP from the non-UIPs. And then when the HRCT results are in, we do another MDD and determine if we need to do more definitive lab works, like for example, bronchoalveolar lavage or surgical biopsy. And then after all of those, another NDD is needed before we diagnose IPF or not non-IPF. So now that we know the role of HRCT in the diagnosis of ILD, let me emphasize first that the radiologic appearances are not specific for the underlying cause of diffuse lung disease, as we've seen from the from the table before. But the pattern and distribution that we see in HRCT are very helpful in narrowing down the differential diagnosis. Now, there are four general radiologic patterns of HRCT fundamental to the interpretation of chest CT scans. And these patterns are reticular opacities, nodules, increased lung opacity, and decreased lung opacity. Now, for our purposes in tonight's lecture, since we're dealing about fibrosis and idiopathic pulmonary fibrosis and usual interstitial pneumonia, we're going to focus more on reticular opacities. And later, when we do our COVID-19 part of the lecture, we're also gonna tackle the increased lung opacities or the ground gas opacities and consolidation that we see in COVID-19 pneumonia. Right, before we move on to the radiologic patterns, let us first review a bit of anatomy that is critical to interpreting HRCT scans. So this slide shows us the left side of the screen shows us a gross pathology specimen of the lung seen at the pleura with the polygonal secondary lobule clearly identified and outlined by special dye. So this is the representation of the anatomy of the secondary lobule. So we see the secondary lobule is the functional unit of our lung. It represents a cluster of 30 acini, and it's bounded by interstitial fibrous septa or our interlobular septa. At the center, we have our centrilobular structures, which are our distal pulmonary artery and our bronchiole. And surrounding our centrilobular structures are our sinus and the rest of the lobular parenchyma. Now, the secondary lobule is the smallest functional unit of the lung that is visible on HRCTs, and they appear as irregular polyhedrons of varying size between 1 and 2.5 centimeters, with central dot representing centrilobular structures. So in this patient, 60-year-old female with lymphangitic carcinomatosis, we see our secondary lobules outlined by the thickened and irregular interlobular septae. So these are our secondary lobules, and these are our thickened interlobular septae. And the one in the middle is the centrilobular structures, which is comprised of the artery and the bronchiole. So as we go peripherally, our lobules are larger and cuboidal and pyramidal. So here. And then as we go centrally, we tend to see that our secondary lobules are cuboidal or pyramidal. Like for example, this one here or this one here. Knowing this secondary pulmonary lobule is key to all the various terminology that we use in HRCT. Now, one of the more common words or terminologies that you would see in the reports of HRCT scans with interstitial lung disease are reticular opacities. So this slide shows us a good example of the subplural reticular opacities, and these result from thickening of the interstitial connective tissue of the lung or the interlobular septa. So remember our secondary pulmonary lobules that we see. Remember, see that they are outlined here on our subpleural area, and also there we also see a lot of these reticular opacities even in the central regions of the lung. Now, this kind of subpleural reticular opacities are very different from interlobular septal thickening that we see in interstitial edema and in lymphangitic carcinomatosis, because these reticular opacities are more heterogeneous, they are more random in appearance, and most of the time they cause irregularity in the pleural interface. So if you look closely at the pleura here, we can see that it's quite irregular because of the reticular opacities. Most of the time in patients with interstitial lung disease, ground glass opacities accompany this fine subpleural reticular opacities. This next slide is an example of honeycombing, which is a type of lung remodeling that reflects end stage of a number of diseases that cause parenchymal destruction. Now, honeycombing is a key feature of UIP, or usual interstitial pneumonia, pattern seen in patients with idiopathic pulmonary fibrosis. And in fact, the UIP pattern category in the guidelines requires that there must be honeycombing in our HRCT for us to categorize this as UIP. Now, in honeycombing, we see these clustered cystic spaces. Usually, most of the time, they're of consistent diameter, around 3 to 10 millimeters, but occasionally they will be larger, and they have thick defined walls. If we contrast it with our reticular opacities, or even with that we seen before. So multiple layers of subpleural cysts can be seen. Like for example, in this patient, there are 2 up to 3 layers of the subpleural cysts that we see on top of each other. But sometimes you also see this single layer. And in this single layer of honeycombing, we also see that this patient has a lot of reticular opacities also. And we also see this reticular opacities here, here, and even here. Um, some of these cysts are accompanied by reticular pattern containing traction bronchiectasis and bronchiolectasis. Now, traction bronchiectasis and bronchiolectasis are key features of pulmonary fibrosis. And this next slide demonstrates them very nicely. Um, Traction bronchiectasis refers to bronchial dilatation occurring as a consequence of interstitial fibrosis. So here we see this dilated bronchi, and we see that they're not tapering as they get to the subpleural region. And surrounding this dilated traction bronchiectasis and bronchiolectasis, we see some honeycombing beside it and some reticular opacities. And even the pleural interface is also irregular if you look closely. So bronchial dilatation occurs as a consequence of interstitial fibrosis, with features ranging from subtle irregularity, non-tapering of the bronchiolar wall, to marked airway distortion and varicosity. So usually in usual interstitial pneumonia, they often coexist with these honeycomb cysts. Now, this next slide is an example of ground glass opacification, which is not typical of UIP and pulmonary fibrosis, but is typical of more acute infection, including COVID-19 pneumonia. It's also seen in diffuse alveolar damage, such as in ARDS or the other IIPs, such as acute interstitial pneumonia and RBILD, and even in desquamative interstitial pneumonia. And in other ILDs, particularly hypersensitivity pneumonitis. So here, ground glass opacity is increased opacity of the lung with preservation of the bronchial and vascular margins. So if we look here, we see that these ground glass opacities here within those areas of ground glass opacities, we can still see some of the vessels, and some of them are still branching like this one. And then sometimes we see some prominent interlobular septa within the area of ground glass opacification. And that's you might have encountered that terminology that we call crazy paving pattern. So that is what we see. We see ground glass opacities with the interlobular septa, and we call it crazy paving pattern. Now, pure ground glass opacities are not typical in UIP, but if we see ground glass opacification superimposed on fine reticular pattern, now that represents fibrosis, and that may be seen in idiopathic pulmonary fibrosis. Now, the 2008 in 2018, the ATS-CRS JRS guidelines includes they categorize the HRCT scan patterns into four. So based on the likelihood of the HRCT features to correspond to UIP. So we have UIP, probable UIP, indeterminate for UIP, and other alternative diagnosis. Now the UIP pattern is the hallmark of radiologic pattern of IPF. Now, honeycombing is a definitive feature and must be present. And with this is with or without traction bronchiectasis or peripheral broncholectasis. The distribution is usually subplural and basal predominant, but almost always there is upper lobe involvement. Um, and then more commonly, there is a symmetric pattern involving both lungs, but 25% of CT scans would have an asymmetric disease. Now, the positive predictive value of radiologic diagnosis of UIP for the pathologic diagnosis of UIP is about 90% to 100%. So showing the good correlation of radiologic and histologic findings. In UIP, other findings include mediastinal lymphadenopathy, which may or may not be present, and ground glass opacities, which may be present, but they must not be dominant, because if the ground glass opacities are dominant, then it's an alternative diagnosis and not UIP. Now, when we see our HRCT and we see a UIP pattern, um, while we might think that it is IPF, remember that in our diagnostic algorithm, we must always exclude first our known etiologies. So among the differential diagnosis of UIP pattern, IPF is our most common, around 60 to 70% of the time. Um, NSIP is another differential diagnosis. We have connective tissue disease and collagen vascular disease, including rheumatoid arthritis. We have chronic hypersensitivity pneumonitis, drug toxicity, and asbestosis. Now let's just go a bit more into the UIP pattern seen in our HRCTs. So again, honeycombing must be present with or without peripheral traction bronchiectasis or bronchiolectasis, and there must be a subpleural and basal predominant distribution. And most of the time, the distribution of heterogeneous but symmetric, and most of the time also the upper lobes are involved. So if we look at this HRCT of a patient with usual interstitial pneumonia, we see here at the lung bases our honeycombing. We see our irregular pleural interface. We see a lot of reticular opacities here. And most of those reticular opacities are accompanied by ground glass opacities. And if we test these series of images, are eggshell slices that goes caudally downwards. So as we go downwards, we see here at the top, at the level of the aorta, we see that there are no honeycombing, but there are a lot of reticulations. As we go downwards here at the level of the aortic root, we see that there are a lot of honeycombing already. And as we get to the level of the diaphragm, there are more extensive honeycombing, and now we see them stacked on top of each other. We still see some if we look here at the coronal view, we still see some traction bronchiectasis here. And this here on the next slide shows another pattern of UIP, but is not as classic as the one that I'd shown before in the first slide. So in this patient, we see that there are a lot of ground glass opacities because the lungs look white compared to this in 4A. But if we look closely at the at the subpleural area, we still see a lot of honeycombing. We see these traction bronchiectasis. So we see this bronchi, they're not tapering, they're dilated, even down to the area of the interstitial fibrosis. And even as we go lower at the level of the left ventricle and the left atrium, we see more extensive honeycombing here at the bases and more extensive bronchiectasis, and they almost look like varicose bronchiectasis now because of the uniformity of the dilatation is irregular. And if we look here at the coronal scan, we see the bronchiectasis here nicely. We see that there are more subpleural and basal predominance of the lesions compared to that on top, on the upper lobe, sorry. This is a representative illustration of the distribution of UIP. So here, this shows us nicely the subpleural and basal predominance of our honeycomb lesions. Here we see our honeycombing. We see our traction bronchiectasis here. We see that there's some bit of ground glass opacities here, opacification compared to the upper lobes. We see some random reticular opacities there as illustrated here in this picture. Well then, the next few slides will go briefly over the other categories that we see in the 2011 guidelines. So this next category is our probable UIP pattern. So again, the same distribution, subpleural and basal predominant. Distribution is often heterogeneous, but now we don't see the predominance of honeycombing. We see reticular pattern with bronchiectasis or bronchiolectasis, and then we see some ground glass opacities. Sorry. So in this patient, we see the reticular opacities at the level of the aorta going down. There's still not much honeycombing, but we see here some bronchiectasis already. Going further down, we see more bronchiectatic lesion, but there's still no honeycombing. So here on our coronal view, we see the basal predominant bronchiectatic lesions, but there's still no honeycombing. So this was classified as probable UIP pattern according to our guidelines. And if I'm and the specific IIP that probably fits it is probably NSIP because of the predominance of the ground glass opacities and the similar pattern to UIP. We then go to the next category, which is the indeterminate for UIP pattern. So indeterminate for UIP, again, we see subpleural and basal predominant lesions. There may be subtle reticulations, so they may have mild ground glass opacities or distortion or an early UIP pattern. But the CT features and the distribution of lung fibrosis do not suggest any specific etiology. So this is truly indeterminate for UIP. So in this patient here at the level of the aorta, we see very minimal reticulations here and here on this side. As we go down at the level of the ventricles, we see ground glass opacities superimposed on fine reticular opacities here and even here on this side. So we still see a subpleural basal predominant distribution here on our coronal view. So this was categorized as indeterminate for UIP. The last category is alternative diagnosis. So for this, we may see other features that suggest another diagnosis. So the CT features include cysts, mosaic attenuation, diffuse ground glass opacities, nodules, consolidation, etc. So the CT pattern usually suggests an alternative diagnosis. So for this patient, The predominant pattern are ground glass opacities, but we still see some traction bronchiectasis here and some reticular opacities there. But overall, we have predominantly basal ground glass opacities with these areas of decreased lucency that is seen in air trapping. And this patient was diagnosed with chronic hypersensitivity pneumonitis. This was discussed earlier by Dr. Albay. So the diagnosis of IPF requires the exclusion of known causes of ILD, the presence of HRCT pattern of UIP, and specific combinations of HRCT pattern and histopathology pattern. So in summary, ILD is an umbrella term, so it encompassing the diverse group of disease that results from damage to cells surrounding the alveoli and leading to widespread inflammation and fibrotic scarring of the lungs. So these major ILDs can be categorized into those of known and unknown etiology. Now, our idiopathic interstitial pneumonias are a diverse group of ILDs of unknown etiology classified into specific histologic patterns and corresponding clinical radiologic pathologic diagnosis. Idiopathic pulmonary fibrosis is defined as a specific form of chronic progressive fibrosing interstitial pneumonia occurring primarily in older adults, limited to the lungs, and associated with histologic and radiologic pattern of UIP. Our gold standard in diagnosing IIP is MDD or multidisciplinary diagnosis. It's not HRCT and it's not the biopsy or histopathologic findings. The primary role of HRCT is to be able to separate UIP from other IIPs and also to provide alternative diagnosis for specific ILDs of known etiology. Now, for our part 2 of our lecture, this will be just a short lecture on COVID-19 and ILD. So, the emergence of the novel severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 in December 2019 resulted in a global pandemic. So, as of yesterday, or actually as of today, there are 183 million cases recorded worldwide and 3.96 million deaths. Many survivors of severe COVID-19 infection have long-term residual abnormalities on HRCT. These residual abnormalities or residual pulmonary disease is sometimes referred to as post-COVID interstitial lung disease. Now, in early 2020 or last year, the RSNA or the Radiologic Society of North America issued an expert consensus statement on the reporting of chest CT findings related to COVID-19. And several papers have found that COVID-19 typically presents with ground glass opacities with or without consolidation in a peripheral, posterior, and diffuse or lower lung zone distribution. So here are typical representative findings of COVID-19. If we look here and letter A, the image A, we see some ground glass opacities here, 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 and here. And most of the ground glass opacities are seen in a subplural peripheral distribution. If you see that. And then if you look closely in this particular ground glass opacity, we can see some prominent interlobular septa, reticular opacities within, and that is the crazy paving appearance that we sometimes see in our results in our COVID-19 patients. This is another typical pattern of COVID-19. Instead of the ground glass opacities that we see in a more peripheral or more subplural distribution, we see these rounded consolidations and ground glass opacities. Majority of them are still in a peripheral distribution. We also see some accompanying ground glass opacity surrounding them. And still there's a basal predominance. So these are still typical of COVID-19 pneumonia. The other typical appearance of COVID-19 is those of an organizing pneumonia-like pattern. So some of the signs that we see in organizing pneumonia are bilateral consolidations like this ones. So these are consolidations. They are in a subplural distribution, and they're also in the perilobular distribution, because if you remember, we discussed earlier that most of the lobules are here and the periphery. So this is a perilobular distribution of consolidations. And sometimes we see this, see with this is what we call the reverse halo sign. So we see an area of ground glass opacity, and there's consolidation surrounding that area of ground glass opacity. So this is different from those seen in aspergillosis, for example, where we see um, an area of consolidation with the halo of ground glass opacity. This is different. This is a halo. This is an area of ground glass opacity surrounded by consolidation. So this, for comparison, here on the left lower is an example of organizing pneumonia. And if you look at organizing pneumonia and COVID-19, you can, even I would be, it would be difficult for me to tell based on CT findings alone. And if I had no history of this patient, I could not tell you if this is organizing pneumonia or this is COVID-19. And even if you look in influenza A pneumonias, they also look similar. So there are a lot of these consolidations with air bronchograms and bronchiectasis. They're still seen in a subpleural basal distribution, and there are some ground glass opacity. So if you may have seen in some of our chest CT results, we always include that the typical COVID pattern of disease. We always include in the differential diagnosis organizing pneumonia and influenza A pneumonia. Now, there are a lot of studies published in 2020 and 2021 that shows that a subset of patients with COVID-19 develop these residual persistent ILD abnormalities after hospitalization. So I chose these two studies because these are they had larger cohorts and larger populations, and they have results that pertain to radiologic findings. So in radiology, Han and Fan et al. Did a prospective longitudinal study on 114 patients with severe COVID-19 pneumonia, and they found out that a third of these 114 patients, or around 30 to 40, recovered from severe COVID-19 pneumonia and developed fibrotic-like changes within 6 months of disease onset. So the risk factors for these are older age, more than 50 years old, development of ARDS during hospitalization, and a higher baseline CT score. So this means that there are more lobes involved in the patient. There are more ground glass opacity seen, etc. And they had more consolidations. And 26% of these patients with fibrotic lung disease had abnormal DLCO at 6 months follow-up. So this is an example of one of their patients that they followed up. So the series of images on the top are 32 days after onset of symptoms. So here we see these perilobular fibrotic-like reticular opacities here. We see this dilated bronchi, retraction bronchiectasis, in association with these fibrotic opacities. We see here some subpleural reticulations and the bronchiectasis associated with it. And as we go down to the level of the diaphragm, we see that the amount of fibrotic-like changes or interstitial opacities are increasing. And then at 6 months after onset of symptoms, we see that there is decrease in the number of in the lesions, but we still see this residual interstitial abnormalities here. We see that this patient has already started to form honeycombing on here at the may basal areas. And then there are a lot of bronchiectasis associated with these honeycombing. Now, another study by Mial and Mukherjee, they did a larger prospective longitudinal study on 837 patients who survived COVID-19 pneumonia. So for this time, they included all patients, mild, moderate, and severe. And they conducted the study in a single center in the UK. Around 7% of all patients had persistent interstitial changes on HRCT, even at 6 weeks after discharge. And 4% of this entire cohort had organizing pneumonia-like pattern of bilateral ground glass opacities, mid to lower lobe distribution, subpleural and peribronchial consolidation, and traction bronchiectasis. Now, all of these patients were offered corticosteroids, which which improved the breathlessness, physical functioning, and improvement of lung function and chest imaging. So this is an example of one of their patients. So the two CT scan slices above are pre-discharge CTs showing organizing pneumonia-like pattern. So organizing pneumonia would have these bilateral patchy consolidations like this one. They are more subpleural in distribution. And sometimes they can be seen in a peribronchivascular distribution as seen here. And here we see those parenchymal bands, these linear opacities that we see lined up along the chest wall. They look like arcades that we see in our churches. And these perilobular fibrosis or perilobular consolidations are typical of organizing pneumonia. And here we see them also. We also see these, if you look here on the left, we see this reverse halo sign here with the ground glass opacity in the middle and area of consolidation surrounding it. And then follow up CD after 3 weeks of corticosteroid treatment. What were left are residual ground glass opacities. Here, you have a lot of subpleural reticulations here. And basically, it's general improvement from here to this one. So there's still a lot of things to learn about post-COVID-19 interstitial lung disease, because most of these studies currently do not extend beyond 6 months follow-up. So more and more research and studies are still necessary to fully understand the clinical course of COVID-19 and to advance our knowledge of the long-term pulmonary sequelae of COVID-19 infection. Thank you very much.
Okay. Thank you, Dr. Oliveros, for that extensive discussion on the CT findings of interstitial lung diseases and especially COVID. So we now open the floor for questions. There is one here, actually 3, I think, yeah, 4. But before we go to the first question, coming from a very prominent colleague. So we would like to congratulate first Dr. Roa, one, for asking the first question, and secondly, for congratulating him because he was elected as one of the newly elected NASP academicians. Congratulations, sir. So his question is, at this time of the pandemic, can we already form MDCs? I think this is multidisciplinary committee, am I right? Who can help guide practitioners on how to manage and prognosticate patients with significant or symptomatic post-COVID lung fibrosis. I think this is directed to Dr. Albay.
Thank you very much, Dr. Rowe. I think that is something that we really need to consider doing because, again, the information on how to manage these patients are quite limited, and decisions with regards to how to go about diagnosis and even managing these patients would need multidisciplinary and a lot of um, people to share, no? And we really gain from experiences from one another. So I think this is something that we should push through. Maybe at the institution levels that you have in your own hospitals or in your own areas. And maybe if it can be also a way to share cases with other institutions and other practitioners.
Okay. So this one probably is directed to Dr. Oliveros before I give my own question. So among symptomatic post-COVID fibrosis cases who have been subjected to a battery of immunosuppressives like dexamethasone, tocilizumab, etc., when should we start thinking of TB? Or probably Albert also can answer after Dr. Oliveros.
Well, in terms of our radiologic findings, so um, one is that we don't usually see honeycombing in tuberculosis. So if you see UIP and if you say UIP pattern in your HRCT, that's most probably another diagnosis other than TB. Aside from that, the other TB also has a lot of scarring and volume loss even in the upper lobes. They would have an upper lobe predominance. We would have a lot of other findings such as we would have a lot of nodules, interlobular nodules. We would have if this is a chronic progressive disease, if we could have destroyed lungs, etc. So basically, what I'm saying is that they have really different radiologic patterns in this case, and TB usually do not usually do not present with these honeycombing that we see in our idiopathic pulmonary fibrosis.
Okay. Albert?
I think because of the symptomatic picture of your post-COVID fibrosis cases, you would really go through a lot of differentials. Try to rule out all of those possibilities that might be coexisting with your patients. Remember, if you give your patient steroids and even tocilizumab, di ba? These are one of the things that can actually cause your TB to start or to flare. So maybe that's one of the things that you will really need to work up your patient for. We did get cases of patients with COVID-19 who had coexisting tuberculosis, no, or TB being diagnosed while they have COVID-19 when we got their sputum smears. No? So it's something that you really need to be looking for, especially in this country where TB seems to be endemic up to now.
Okay. So is it wise that we also do our diagnostic tests for TB as far as sputum is concerned?
I think if we're going to look into the algorithm, even that has been proposed from the ATS, TB will always have to be something that we need to check. So I think part of the diagnostics, we have HRCT, serology, and PFTs. TB testing would probably be something there as well that we really need to consider.
Thank you. So I've been talking to some colleagues about some patients who are still in the hospital and they're hardly thinking of already starting pulmonary fibrosis. And some of them are actually starting medications already for pulmonary fibrosis while the patient's still in the hospital. No? So with the scarce information that we have on the medications for interstitial fibrosis in COVID, is it actually wise to start them early on, especially if the suspicion is high in patients who are at high risk for development of interstitial fibrosis?
I think the thing there is when you look into these cohorts, not all of them who developed this critical COVID-19 and who had these very bad pictures of CT scans will eventually go into a pulmonary fibrosis. So it's not 100%. So that's why starting them in their acute phase on these antifibrotics might not be really that sound. I would still go for monitoring your patients and looking into their progression and symptomatology later on, before you start your antifibrotics. Considering that their antifibrotics might be costly and they are not free of side effects. So, and then if you are going to use these antifibrotics for your patients, this would be in an off-label use. So you will really need to discuss this with your patient and their family about the potential side effects, and that this would be an off-label thing. Again, if you look into the pathophysiology, it would seem that at certain points of the COVID-19 cascade, at least on a pathophysiologic point of view, some medications might be useful. So if you're on the organizing pneumonia part, your steroids might be the way to go about there. But if you are on the fibrotic phase, then maybe your antifibrotics will be working. The problem is knowing when your patient is already on the fibrotic phase and when you are still on the organizing pneumonia phase. So I think that is something that we will really need to trench out later on. We do have some clues on the CT scan to show that this is an organizing pneumonia or this is already part of a fibrosis. And that might be a point of discussion in these multidisciplinary conferences, and to really help whether pinpoint at what phase of the COVID-19 progression in the lungs is your patient in.
Thank you. There are two questions here which I think are related. No, this comes from Lacan, Beracho, and Lemley. How long can we give steroids in post-COVID-19 fibrosis? And what is the role of ICS in the treatment of IPF and post-COVID ILD? I think that's for
So, mhm. So again, the steroids for post-COVID-19 fibrosis, the question there is still the duration. We still don't know. I think these are times wherein you will really look into the symptomatology of your patient, look into whether you are improving or not, and then consider the next steps in your management. There's still no rough rule on when to start, when to initiate. But I think the way to go about it is really review your case and know which part of the ARDS picture you are in when it comes to these groups of patients. We still don't know the dose even of how much to give. Should you be tapering? Should you be giving high doses? Should we be pulsing this patient? Some of these patients with post-COVID-19 sometimes present with an NSIP-like picture or a COP-like picture in their CT scan. So these patients will likely respond to steroids. So if we look into the way NSIPs and COPs have been managed, they're really managed with short-term high doses of steroids. No? So this might be the way to go for some of these patients. Again, extrapolating data from managing non-COVID related NSIPs and non-COVID related organizing pneumonias.
So I think related to that is a question from Dr. Albert Santos. Comments on dexamethasone versus methylprednisolone, especially on cases started initially with the standard recommendation of low-dose dexamethasone with progressing hypoxemia. Your experience?
There are cases wherein we do escalate our steroids. I sometimes change my steroids from dexamethasone to methylpred for the reason that I know that the penetration in the alveoli, based on the studies, when you look into the bile fluid, the penetration for your methylpred seems to be higher compared to your other types of steroids. So that's why I would sometimes shift my patients, especially if I don't have any more else to give and my patient is having progressive hypoxemia. The DexARD study would also tell us that maybe there is benefit to start your patient on a higher dose of steroids and then tapering them after 5 days to a lower dose. So those are studies that may be of use for you when you are trying to decide whether to place your patient on a higher dose of steroid or shifting them to another form.
So I'll go through some of the steroid thing here. No, there's another one again from Dr. Albert Santos. Would you agree if we tailor our steroids rather than fix 6 milligrams dexamethasone 10 days Will it have an impact in lessening future fibrosis?
I think we have to balance off the impact of fibrosis. Again, not all patients will go into fibrosis. And the reason why you are giving the dexamethasone is really to contain the inflammatory response for the cytokine storm as well. So you need to balance it off as well with the possibility of you developing nosocomial infections. So it would really look, you would really need to look into how your ICUs are, whether you have a high risk of developing VAP or HAP inside your ICU. So you need to really tailor fit that and maybe personalize in an individual basis.
This is from Dr. Ivan Vilgaspin. Congrats to our two speakers, high-yield lecturers. Congratulations. And then this is, I think, directed to Dr. Oliveros. Isn't there honeycombing in TB bronchiectasis?
From most of the cases that I've seen in lung centers, especially those with severe TB with really those extensive bronchiectatic changes, I um, I don't see that much honeycombing in it. It's not as common as we think. Especially the honeycombing that I presented in the lecture before, where there is uniform 3 to 10 millimeter sizes of uniform cysts, and there is a bibasal symmetric appearance. And if we see for example, if we have this patient with TB and we see this honeycombing, these types of honeycombing in a typical distribution of interstitial lung disease, then maybe there is a concurrent interstitial lung disease. But for tuberculosis itself, well, at least in my practice, I don't see a lot of honeycombing as I defined it before, or as the guidelines defined what honeycombing is. Yeah, that's it, sir.
Another question from Dr. Bobby Trillas here. Uh, for Dr. Oliveros again. Is reactive LAD common Hrct findings in COVID patients?
Um, Again, it's not. It may be seen in these patients, but it's not a common finding. So for what we really depend on our COVID-19 patients are those subplural peripheral groundless opacities and the organizing pneumonia-like pattern in the diagnosis of COVID-19.
And lastly, I think it's just a comment from Dr. Dina Diaz. Antifibrotics have potential hepatotoxic side effects and risk of bleeding. So warning about using them if not really indicated yet, especially while awaiting the results of the clinical trials. So I guess anyone else who would like to ask? Because that's all that's written in the chat box. Thank you very much, Dr. Alday and Dr. Everest, for sharing your knowledge.
Thank you.
Okay, so this has been a very productive evening, very exhausting and very extensive discussion. So before we close, I would like to call in our gorgeous president, Dr. Greg Ocampo, who will pitch in for Dr. Alday Garcia's problems with her internet. Dr. Ocampo, for your closing remarks, please.
Thank you. Thank you, Dr. Talia, for that. Pleasant evening to everyone. Let me first congratulate the Philippine College of Chest Physicians Southern Tagalog chapter for their first chapter-initiated CME. And of course, to the esteemed speakers and our moderator, Dr. Cynthia Talia, for this very timely scientific lecture on rediscovering interstitial lung disease in the COVID era. As you all know, the objectives of this initiative is to promote inclusivity and participation of the chapters in the Philippine College of Physicians, Chest Physicians activities in order to devolve and engage our members from the different areas of the country. Of course, this initiative is through the efforts of our PCCP Board of Directors in charge of chapters and CME, who are the ever-reliable and dynamic Dr. Eileen Aniceto and Dr. Lai Garcia. Our gratitude to them, and of course to our chapter presidents and members, their cooperation the pursuit of excellence in our college. So once again, congratulations to the Southern Tagalog chapter. Before that, I think we have, I want to mention the next chapter initiated CME, and this would be brought about by our Northeast Luzon chapter, COVID-19 associated bronchiectasis. This will be on Saturday, July 10, 6 p.m. And we also have our pharma-initiated CME. So this would be on July 6, Tuesday, post-COVID fibrosis, a discussion on post-COVID fibrosis from our guest speakers and principal investigators, Dr. Joel Sanchagel and Toby Maher of California School of Medicine. And on July 7, we from Novartis, scientific exchange among experts, how do we get our patients to treatment goal? So this will be on July 7, 2021. So with that, again, congratulations to the Southern Tagalog chapter. Stay safe, everyone, and have a good evening.
Thank you, everyone. Good evening. See you next week. Bye.
Thank you.
Thank you.